Welcome back to the deep dive.
Great to be here.
If there's one system in the body that just demands such meticulous, high-stakes assessment, it has to be the endocrine system.
Oh, absolutely. These tiny glands, they control everything. And when they fail,
Everything. And the consequences are so swift, so systemic, and often, well, life-threatening.
that's it, exactly.
So today, we are doing an exhaustive deep dive into the assessment and management of patients with endocrine disorders. Our source material is a real blueprint for clinical practice.
And our mission here is to really transform these complex hormonal balances into clear, actionable nursing knowledge.
Giving you that ultimate shortcut to safe, expert management.
That's exactly right. I mean, we're navigating a landscape where the hormones are the master orchestrators. And because they regulate nearly every cellular function from your metabolism to how you adapt to stress, a slight imbalance could just create these massive, multifaceted patient presentations.
And that's the real challenge for us, isn't it? Recognizing that these subtle, general complaints like fatigue or weight change can actually be masking an impending crisis.
Exactly. We have to know the assessment pathway and the percent mechanisms of hyper and hypofunction.
Okay, let's start with the big picture then. We often think of the nervous system as the body's rapid responder, but the endocrine system, that's the long game strategy. So if you had to summarize its function, what are the, say, 6 core areas that these chemical messengers are regulating?
The functions are incredibly broad and, absolutely indispensable. The source points to 6 critical areas.
Okay.
First, control over metabolism and how chemicals get across cell membranes. Then, regulation of growth and development.
Right.
Then there's managing fluid and electrolyte balance. And because of that, acid-base balance.
Makes sense.
Also, facilitating the body's adaptation to all kinds of stressors, internal and external. And finally, of course, governing reproduction. It really is the systemic control tower.
It is. And when we talk about hormone production, the obvious places come to mind, the thyroid, the adrenals.
Sure.
But the body is so much more creative in where it sources these powerful chemical transmitters.
Absolutely. And it's so important to remember that hormone production goes way beyond just the specialized endocrine glands.
Like where?
Well, we see hormones produced by the GI mucosa, things like gastrin, secretin, that regulate digestion. The kidneys produce erythropoietin, which, stimulates red blood cell production.
Right, which you don't always think of as a hormone.
Exactly. Even white blood cells contribute. They produce cytokines, which are these hormone-like proteins that are incredibly active in inflammation and immune responses. The system is it's integrated across the entire body.
And that integration, it reveals this really profound crosstalk between the endocrine, the nervous, and the immune systems. What's a perfect example of a chemical that plays in both worlds?
Epinephrine is the classic one. It functions as a neurotransmitter when the nervous system releases it, sending signals across the synapse.
Right, super fast.
Super fast. But when the adrenal medulla secretes it into the bloodstream, it's a true hormone, traveling to distant cells to exert systemic effects.
And the immune system connection.
The immune response is heavily modulated by endocrine chemicals, specifically the adrenal corticosteroids. They are potent regulators of inflammation. It's a dynamic trio, just constantly interacting.
It sounds incredibly complex, but it's all managed by a relatively simple concept: the negative feedback mechanism. Can you walk us through how this thermostat works?
Yeah, think of it like a sophisticated, self-regulating furnace. The negative feedback mechanism is the primary internal regulator for the whole system.
Okay.
So when the concentration of a circulating hormone, let's use cortisol as an example, rises above the required set point, that high concentration sends an inhibitory signal back.
Back to the pituitary or hypothalamus.
Exactly, telling them to stop stimulating its production. And conversely, if cortisol levels drop too low, the stimulation kicks back in.
So it's this constant self-correction.
Constant self-correction. It prevents dangerous peaks and troughs and keeps the hormone concentration steady. And that's why endocrine dysfunction is so dramatic. It's a fundamental breakdown of this internal thermostat.
Okay, let's get into the structure of these messengers, because their chemical makeup really dictates how they work, and just as important, how fast they work. I understand we categorize hormones into 4 structural types.
Correct. We have 4 major categories. First, you have the amines and amino acids like thyroid hormones and epinephrine.
Okay.
Second is this vast group of peptides, polypeptides, proteins, and glycoproteins. That includes pituitary hormones like growth hormone and TSH. Third are the fat-derived hormones, the steroids, the ones from the adrenal cortex. And finally, fatty acid derivatives like retinoids.
And that structural difference is the key to understanding where they act, which brings us to paracrine versus autocrine action.
Right. So most hormones are systemic. They get into the bloodstream and act on cells far away. But paracrine action is super localized. The hormone only acts on neighboring cells right in the immediate vicinity.
Like in the ovaries.
Exactly. Sex hormones acting locally within the ovaries. And even more localized is autocrine action, where the hormone acts directly back on the very cell that released it.
Oh, wow.
Yeah, a great example is insulin acting on the pancreatic beta cells that just produced it. It's localized self-regulation.
This leads us to what I think is the most fascinating difference, speed. The way water-soluble hormone, the peptides work is totally different from the lipid-soluble ones, the steroids.
Yeah.
Let's start with the second messenger system.
Okay, so this is the rapid response team. Peptide and protein hormones are water-soluble. That means they cannot get through the lipid-based cell membrane.
So they're stuck outside.
They're stuck outside. They have to dock with specific receptors located on the cell surface. This docking action stimulates an enzyme inside the cell, adenyl cyclase, which then dramatically increases the concentration of something called cyclic AMP inside the cell.
And cyclic AMP is the second messenger.
That's the one. It relays the signal internally, triggering these really rapid changes in enzyme activity. You can see effects in minutes, sometimes even seconds.
So now contrast that with the steroid hormones, the ones that take the slow and steady path.
Right. Because steroid hormones are small and lipid-soluble, they just bypass that surface receptor completely. They just diffuse right through the cell membrane into the cytoplasm.
No second messenger needed.
Nope. Once inside, the hormone binds to an internal receptor. This new hormone receptor complex then moves into the nucleus, where it acts directly on the cell's DNA.
It's actually changing the cell's programming.
It literally modifies the DNA to synthesize new proteins. It's changing the cell's machinery from the inside out. And this whole process is much, much slower. It often requires several hours to exert its full effect.
Which is so important to remember when you're treating a patient with replacement steroids. You know the clinical effect won't be instantaneous.
Exactly. Patience is key.
So the assessment of the endocrine patient is notoriously challenging. I mean, the initial complaints, fatigue, mood swings, weight changes are so nonspecific. If we're conducting a health history, what are the critical high-yield questions we have to ask to start narrowing the focus?
You have to cast a very wide net, but you need to focus specifically on changes from baseline and the severity of those changes.
Right.
So key areas include energy levels, and not just fatigue, but chronic lethargy. Tolerance to heat or cold is a big one.
A really big one.
Significant changes in weight without dieting, changes in thirst, urination frequency, bowel function is chronic constipation a new thing?
Right.
And we also have to ask about specific body changes, body proportions, hair loss or growth, menstrual changes, and any psychological issues like memory loss, anxiety, or depression.
You really have to quantify the effect on their daily life, on their self-perception, because those physical changes, a moon face, a deepening voice, they can be psychologically devastating.
Absolutely devastating.
Okay, so moving to the physical assessment, what are some of the classic visual markers we should be looking for in that head-to-toe inspection?
Always start with vitals and always compare to baseline. Especially look for orthostatic hypotension. Then you move to those unique visual clues that just scream endocrine. Look for facial changes like the full moon face or the abnormal eye protrusion of exophthalmos.
Right, from Graves.
Exactly. Inspect the trunk for a buffalo hump, that fatty pad on the back of the neck. Examine the skin meticulously for thinning, easy bruising, purple striae, or the hyperpigmentation you see in Addison's.
And neurological status.
Huge. Check for nervousness versus profound lethargy, and you have to test for hyperreflexia.
Let's really focus in on the thyroid gland itself. What's the proper technique for palpation, and what are we trying to locate?
You usually inspect first. Ask the patient to slightly extend their neck and swallow. Normally, the thyroid tissue will rise with the trachea. Palpation can be done from the front, but it's often easier from the posterior position. What we're trying to feel for is the isthmus, which is the only part of the gland you can normally feel in a non-obese neck.
And if you do feel an enlargement,
Then you have to note the texture. Is it soft, maybe suggesting Graves? Is it firm, suggesting Hashimoto's or even malignancy? Is it tender? That might point to thyroiditis.
and what's the most important clinical sign to listen for if a goiter is present?
You must immediately auscultate. An enlarged gland, especially in hyperthyroidism, often has such massive blood flow that you can actually feel a vibration, a palpable thrill, and you can hear a rushing sound, a bruit, over the thyroid arteries.
And hearing that bruit is a huge clinical sign.
It's a powerful sign of an overactive hypervascular gland. It points very strongly to Graves' disease.
Okay, let's talk diagnostics. Beyond basic blood and urine tests for T3, T4, and metabolites, what's the crucial practical disadvantage of the 24-hour urine collection? It's required for conditions like pheochromocytoma, but it's a real bear.
The disadvantage is its notorious unreliability if it's not done perfectly.
Right.
And the burden it puts on the patient is immense.
Right.
The collection has to be initiated at a precise time. It has to be stored correctly, often refrigerated, sometimes needing a preservative, and the patient cannot miss a single voiding over 24 hours.
And any mistake invalidates the entire test.
The whole thing is invalid. It leads to delays in critical diagnoses, like pheochromocytoma. This demands really thorough patient education and clear nursing supervision.
Now, I think the most intellectually satisfying diagnostic method is dynamic testing, where we deliberately manipulate the hormonal system. It's a real critical thinking test. How do stimulation tests help us pinpoint hypofunction?
Stimulation tests help us locate the source of the problem. Is it the central office, the hypothalamus or pituitary, or is it the local factory, the target gland? So we administer a stimulating hormone that usually comes from that central office. If the target gland, say, the adrenal cortex, responds by releasing its hormone, we know the factory is working. The problem is higher up.
Secondary or tertiary hypofunction.
Exactly. But if the target gland fails to respond, we know the factory itself is broken. That confirms primary hypofunction.
And conversely, how do suppression tests prove hyperfunction?
Suppression tests prove that the negative feedback mechanism is broken. We give an exogenous dose of the target hormone. Normally, this should suppress the body's own production. But if we give a high dose of, say, a glucocorticoid, and the body's natural cortisol secretion is not suppressed,
it confirms hyperfunction.
it confirms it. It means the gland is ignoring the normal regulation
Right.
and is just secreting autonomously, often because of a tumor.
Okay, finally, let's drill down on the mandatory nursing alert about preparing for diagnostic tests, especially related to iodine exposure.
This is a major, major safety point, particularly before any test involving iodine uptake or contrast. You have to ask about previous reactions. And while the source notes that a shellfish allergy is due to proteins, not iodine, you still have to be extremely cautious. We must thoroughly assess for all sources of iodine exposure.
So not just contrast dye.
Not at all.
Yeah.
5E contrast from previous scans, radioactive iodine exposure, certain medications, and even high iodine foods like kelp or seaweed supplements.
And the list of medications that can throw off thyroid function tests is huge. Why is documenting that so crucial?
Because if the patient is on medications like amiodarone, lithium, estrogens, phenytoin, or even large doses of aspirin, these drugs can profoundly alter TSH and T4 results.
So they could make a euthyroid patient look hypothyroid or vice versa.
Precisely. And if those medications aren't noted and factored in, the diagnostic team might end up treating a completely incorrect diagnosis. The nurse is responsible for that meticulous documentation and communication.
Let's shift our focus to the pituitary gland, the so-called master gland, sitting just inferior to the brain. The anterior pituitary manages a whole suite of 6 major hormones, including growth hormone, which is the most abundant one. What does GH regulate in adults, given that their growth plates have already fused?
Right. So in children, GH is all about long bone growth. But in adults, GH becomes a critical metabolic regulator.
Okay.
It increases protein synthesis, it promotes the breakdown of fatty acids for energy, and it elevates blood glucose levels. If secretion is naturally pulsatile, it spikes during deep sleep, exercise, or stress.
So now let's talk about the hypersecretion syndromes. Oversecretion of ACTH leads to Cushing's, which we'll get to, but oversecretion of GH creates 2 really distinct conditions, depending on the age of onset.
That's right. If the GH excess happens in childhood, before the epiphyseal plates fuse, the result is pituitary gigantism.
Right.
And this often leads to people exceeding 7 or even 8 feet in height.
But if that excess GH starts in adulthood,
that's when you get acromegaly. Since the long bones can't lengthen anymore, the excess hormone causes this severe enlargement and thickening of peripheral parts and soft tissue.
what does that look like clinically?
We see progressive enlargement of the hands and feet. Patients often have to change their shoe size multiple times. You see thickening of the nose, chin, and molar eminences, which leads to prognathism, a protruding jaw.
And what about other symptoms?
Headaches and visual disturbances are major symptoms. This is because the pituitary tumor often starts to impinge on the optic nerves, which can lead to visual field cuts or even blindness.
Let's talk about the pituitary tumors themselves. They're usually benign, but the most common type actually causes hypofunction, right?
That's the chromophobic tumor. It makes up about 90% of pituitary tumors. They are typically non-functional, meaning they don't secrete hormones themselves.
So their danger is just their physical presence.
Exactly. They grow and destroy the surrounding normal pituitary tissue, leading to hypopituitarism, a generalized insufficiency of all the pituitary hormones.
And clinically, what does that manifest as?
It's a generalized systemic slowing. You see obesity, somnolence, a low basal metabolic rate, subnormal body temperature, and hair loss.
The primary treatment for these tumors is hypophysectomy. What does the nurse need to really emphasize about the post-surgical requirements?
A hypophysectomy, which is often done transphenoidally, means the patient loses the central control center for many other glands. Consequently, the patient requires lifelong replacement therapy. This is absolutely non-negotiable.
Specifically, what are they replacing?
They need replacement corticosteroids and thyroid hormone because the stimulus from the pituitary ACTH and TSH is now gone.
Right.
This is a critical teaching point for patients and their families.
Okay, shifting to the posterior pituitary, now we're focused entirely on fluid management regulated by vasopressin or ADH.
Right.
Let's tackle the deficiency state first.
Right.
Diabetes insipidus or DI. What's the consequence of not having enough ADH?
The consequence is a total failure to conserve water at the renal tubule. This leads to a massive, uncontrolled excretion of very, very dilute urine.
And the clinical picture is pretty dramatic.
Oh, it's striking. An output often exceeding 250 millimoles per hour, sometimes 18 to 20 liters a day, with an incredibly low specific gravity, typically 1.001 to 1.005.
And we categorize the cause into 3 types. Which ones are the most responsive to hormone replacement?
So central DI is the most common. It involves damage to the hypothalamus or posterior pituitary, often from head trauma, surgery near the pituitary, or tumors. This type responds really well to ADH replacement.
Then the other 2?
Nephrogenic DI is a kidney problem. The tubules just don't respond to ADH, often caused by kidney injury or lithium toxicity. So that requires managing the kidneys, not replacing the hormone.
Oh.
And dipsogenic DI is related to a hypothalamic defect in the thirst center.
If a patient with DI can't manage their intake, what is the immediate life-threatening danger we need to monitor for?
The immediate high-stakes danger is the rapid onset of hypernatremia and hypovolemic shock.
Right.
Even if you restrict the patient's fluid intake, that massive dilute urine output just keeps going. They can quickly become dangerously dehydrated, leading to severe hypernatremia, decreased cardiac output, and shock.
Which brings us to the fluid deprivation test, the definitive diagnostic tool. It sounds risky. How is this procedure managed safely in a clinical setting?
It is risky, and that's why it requires continuous nursing observation. We withhold fluids for 8 to 12 hours, or until 3% to 5% of the patient's body weight is lost.
Wow.
Yeah, we weigh the patient frequently, often hourly, and we test their plasma and urine osmolality. The inability of the body to concentrate that urine confirms DI.
And what are the absolute termination criteria? When do you stop the test?
The test must be stopped immediately if the patient shows any signs of severe dehydration, significant weight loss, tachycardia, or orthostatic hypotension. You are deliberately putting them into a water deficit, so continuous monitoring of their cardiovascular status is absolutely essential.
For management, desmopressin is the drug of choice for central DI. What is the crucial caution regarding the use of vasopressin, the natural hormone?
The natural hormone, vasopressin, is a potent vasoconstrictor. While it's effective at reducing urine output, it has to be used with extreme caution, if at all, in patients with known coronary artery disease.
Why is that?
Because it can induce coronary vasoconstriction and trigger angina, or even a myocardial infarction. Desmopressin is preferred because it has fewer of those vascular effects.
Makes sense.
And for nephrogenic DI, where ADH doesn't work, we actually use counterintuitive treatments like thiazide diuretics and prostaglandin inhibitors to reduce flow to the distal tubule.
Okay, let's flip the switch to the opposite problem. Syndrome of inappropriate ADH, or SIADH. What happens physiologically when that negative feedback loop fails, leading to excessive ADH?
The body just keeps secreting ADH even when the plasma osmolality is low. This causes the kidney to retain water inappropriately.
So the result is fluid volume excess.
Fluid volume excess and the key clinical finding. Dilutional hyponatremia. There's just too much water diluting the sodium in the bloodstream.
What are some of the common, often non-endocrine causes that can trigger SIADH?
Yeah, the source really emphasizes that many cases are caused by conditions outside the CNS. The most frequent non-endocrine cause is bronchogenic carcinoma lung cancer, where the malignant cells actually synthesize and release ADH ectopically.
Wow.
Other causes include CNS disorders like head injury and certain medications like vincristine that stimulate ADH release.
So the nursing focus for SIADH is intense, particularly regarding their neurological status. Why?
Because the primary danger of hyponatremia is neurological compromise. As sodium levels drop, especially below 120, the brain swells.
On the symptoms.
They can range from headache, lethargy, and a change in personality all the way to seizures, coma, and death. So management focuses on finding and eliminating the cause and aggressive fluid restriction to allow that sodium level to normalize.
What about severe, life-threatening hyponatremia?
If the sodium drops dangerously low, we may have to administer 3V hypertonic saline, which is 3% ACL.
Which is a high-alert medication.
A very high-alert medication. Yeah. It has to be given slowly and cautiously, often through a central line, because giving it too quickly risks osmotic demyelination syndrome, a severe neurological disorder. The nurse has to be on top of INO, daily weights, and continuous neurological checks.
Moving on to the thyroid gland, the metabolic master. What's the fundamental difference between T3 and T4, and why do they impact every single system in the body?
So T3, or triiodothyronine, is about 5 times more potent than T4, thyroxine, and it acts more rapidly.
Okay.
Both hormones increase the body's consumption of oxygen and energy. They regulate the basal metabolic rate, thermogenesis, and the function of nearly every organ, from your heart rate to peristalsis. When this system is in balance, we call the patient euthyroid.
Hyperthyroidism is a state of excessive hormone output. The most common cause, especially in women, is Graves' disease.
Right. Graves' disease is the classic example of an autoimmune disorder driving hyperfunction. Circulating immunoglobulins mistakenly stimulate the TSH receptors on the thyroid.
So they're constantly telling the thyroid to produce more T3 and T4.
Exactly, regardless of the body's actual need. This is why women, who are 8 times more likely to develop it, often report symptoms popping up after periods of extreme emotional or physical stress.
Can you describe the clinical manifestations using that systemic acceleration framework? What does that look like?
Everything is just an overdrive. Metabolically, they are burning hot, heat intolerance, excessive perspiration, increased appetite, and profound weight loss despite eating constantly. Neurologically, they're anxious, restless, emotionally labile, and they often have a fine, almost invisible tremor in their hands. And cardiovascularly, we see persistent tachycardia and palpitations, which, if left untreated, can lead to heart failure.
And what about the specific recognizable sign of Graves' disease?
That would be exophthalmos, the classic abnormal protrusion of the eyeballs.
And what causes that?
It's due to edema and a buildup of fluid and fat behind the eyes. And it's a really critical point that the ocular signs often do not reverse completely, even when the hyperthyroidism is successfully treated.
So that leads to chronic eye care needs and a lot of body image distress?
A huge amount.
When you're assessing the thyroid gland itself in a patient with Graves', what 2 signs suggest extremely high blood flow?
You might find an enlarged gland or goiter that's very soft and pulsatile. You might even feel a thrill, a palpable buzzing over the area.
And you have to listen.
You absolutely have to auscultate for a brute. Hearing that rushing blood flow confirms the hypervascularity that is just characteristic of a gland driven into overdrive. The labs confirm it with a low TSH and a high free T4.
Okay, let's look at management. Radioactive iodine therapy, or 131I, is the primary non-surgical choice. What is the expectation, and why is this treatment so effective?
The expectation is that a single dose will permanently destroy enough thyroid tissue to cure the hyperthyroid state in 80% to 90% of cases.
Wow, that's really effective.
It is. The isotope is concentrated exclusively in the thyroid, which makes the treatment highly targeted and safer than external radiation. But the inevitable outcome is that almost all patients will eventually develop hypothyroidism.
Which is much easier to manage.
Much easier to manage lifelong than the hypermetabolic state.
What are the strict patient safety and radiation protocols that the nurse has to communicate?
The patient is temporarily radioactive, so they have to take measures to protect others. Absolute contraindications are pregnancy and breastfeeding.
Right.
And the patient teaching has to include avoiding sexual contact, sharing utensils, and prolonged close contact with children and pregnant women for several days to weeks, depending on the dose. Nurses have to instruct the patient on specific handling of bodily fluids and linens to prevent contamination at home.
Now, for antithyroid medications, the thionamides like propylthyrosol, PTU, and methimazole, what is the singular non-negotiable safety alert tied to these drugs?
A granulocytosis. It's a severe, dangerous reduction in white blood cells.
So what do we teach the patient?
They have to be taught that if they develop a fever, a sore throat, or mouth ulcers, any sign of infection, they must stop the medication immediately and call their physician. These symptoms can indicate a fatal bone marrow suppression.
Mm-hmm.
And it's also worth noting that PTU has a risk of hepatotoxicity, which is why methimazole is often the preferred long-term drug.
What adjunctive therapy is crucial for symptom relief while you're waiting for those thionamides to take effect?
Beta-adrenergic blockers, like propranolol, are essential. They don't affect the hormone synthesis, but they immediately block the severe sympathetic symptoms.
Like the tachycardia and the tremor.
Exactly. The tachycardia, the tremor, the nervousness, they are critical for stabilizing the patient, especially right before surgery or in the lead up to radioactive iodine effects to prevent a storm.
And thyroid storm is the ultimate complication of hyperthyroidism, a high-mortality endocrine emergency. If a nurse suspects this crisis, what is the immediate life-saving triad of manifestations they have to identify?
You have to recognize the extreme rapid acceleration. First, hyperpyrexia, or a severe high fever, often spiking above 101.3 degrees Fahrenheit.
Okay.
Second, extreme tachycardia, often exceeding 130 beats per minute, which leads to severe cardiac and GI disturbances. And third, a profound alteration in mental status, ranging from frank delirium and psychosis to somnolence and coma.
And it's often precipitated by some kind of external stressor, right? What are the common triggers?
Infection is the most common stressor, but also non-thyroid surgery, severe emotional shock, trauma, or, dangerously, the abrupt, non-adherent withdrawal of antithyroid medications.
Management priorities are intense and immediate. Let's focus on temperature reduction because there's a vital, specific medication exclusion here.
Right. The goal is aggressive cooling. We use a hypothermia blanket or ice packs, but the crucial point is the medication. You must use acetaminophen only.
Only acetaminophen.
Aspirin or any salicylates are strictly contraindicated.
Yeah, why is that?
Because aspirin actually displaces thyroid hormone from its protein binding sites. So it acutely raises the amount of free, active thyroid hormone circulating in the bloodstream, which instantly worsens the hypermetabolic state and exacerbates the crisis.
You're literally fueling the fire.
You're fueling the fire.
Yeah.
Exactly.
What are the other three immediate pillars of management for thyroid storm?
1. Oxygenation and airway management. The high metabolic rate demands humidified oxygen. 2. IV fluid and glucose replacement.
Mm-hmm.
IV fluids with dextrose are essential because the patient's liver glycogen stores are just rapidly depleted by the hypermetabolism, putting them at risk for hypoglycemia.
And third?
Third, blocking hormone release. You administer high doses of antithyroid medication like PTU, followed by iodine solutions like SSKI, to quickly prevent further release of T4 from the gland. Hydrocortisone is also often given to manage potential adrenal insufficiency or shock.
Moving to the deficiency state, hypothyroidism. The most common cause in adults is autoimmune, Hashimoto thyroiditis. If the clinical picture for hyperthyroidism is acceleration, what's the picture for hypofunction?
It's one of profound deceleration. The patient is fatigued, chronically lethargic, suffers from cold intolerance, has dry, flaky skin, and often experiences weight gain despite a poor appetite.
And cardiovascularly?
You see bradycardia and decreased cardiac output. Cognitive function is dulled. They might appear apathetic, and their speech is slowed.
When this progresses to its severe, long-standing state, we see myxedema. What is the pathophysiology behind that characteristic appearance?
So myxedema is the accumulation of mucopolysaccharides in the subcutaneous tissues. This leads to a non-pitting edema, especially noticeable around the eyes and hands.
And it gives them that classic look.
It does. A mask-like, dull, puffy face and thickened skin.
Myxedema coma is the life-threatening decompensated state. What are the two primary causes of death in this crisis?
Myxedema coma is usually precipitated by an infection or exposure to cold, or dangerously, the use of sedatives or narcotics.
Mm-hmm.
The two main causes of death are respiratory failure. The profound depression of the respiratory drive leads to alveolar hypoventilation and CO2 narcosis, and cardiovascular collapse from hypotension, bradycardia, and associated hyponatremia and hypoglycemia.
Management is centered on hormone replacement with levothyroxine. This brings us to the crucial cardiac safety alert for initiating therapy. Why must the dose be started low and titrated extremely slowly, especially in the elderly?
This is a life-saving nursing concept. Long-standing hypothyroidism is often associated with atherosclerosis.
Right.
So when you suddenly introduce levothyroxine, the drug rapidly increases myocardial oxygen demand. If the heart's blood supply is restricted by that pre-existing atherosclerosis, the increased demand can't be met.
And that can lead to angina, arrhythmias, or an MI.
Exactly. The dose has to be started low, and the patient must be monitored continuously for any cardiac symptoms. If angina or arrhythmias appear, the dose must be held immediately.
And the medication caution regarding hypnotics and sedatives is equally critical.
Absolutely. Hypothyroid patients have profoundly slowed metabolism and decreased respiratory reserve. They are exquisitely sensitive to sedatives, opioids, and hypnotics.
So what's the standard of care?
The nursing standard is to administer only 1/2 or 1/3 of the normal typical dose for a patient of a similar age and weight. This is to prevent profound sedation and fatal respiratory depression.
Let's summarize the key nursing interventions for myxedema coma. We have to address respiratory, cardiac, and temperature management.
Okay, so respiratory airway maintenance is paramount. Often this requires mechanical ventilation. Cardiac, continuous ECG monitoring is needed, and we initiate hormone replacement with IV levothyroxine very cautiously.
Then temperature.
For temperature, use passive rewarming, only extra blankets, a warm environment. We must strictly avoid external heat sources like electric blankets or heating pads.
And why is that?
Because external heat can cause peripheral vasodilation, which in a state of hypovolemia and cardiac depression can trigger a rapid drop in blood pressure and subsequent vascular collapse.
And finally, teaching.
We teach patients that the cognitive changes are reversible with therapy, and we emphasize lifelong adherence.
Let's move to the parathyroid glands, which are situated behind the thyroid. Their hormone, PTH, regulates what? 2 minerals?
PTH is the primary regulator of calcium and phosphorus. Its job is to increase serum calcium by promoting its release from bone resorption, enhancing its absorption from the GI tract, and increasing its reabsorption from the kidneys.
And it lowers phosphorus.
Exactly. It's a classic negative feedback loop. High calcium suppresses PTH, and low calcium stimulates it.
So hyperparathyroidism is characterized by excessive PTH, leading to hypercalcemia. What are the major complications famously summarized as stones, bones, and groans?
Right, so the high serum calcium pulls calcium out of the bone, causing bone demineralization, osteoporosis, bone pain, and pathologic fractures. That's the bones. The excess calcium is excreted by the kidneys, which predisposes the patient to nephrolithiasis or renal calculi. The stones...
And the groans.
Systemically, hypercalcemia causes apathy, muscle weakness, and GI symptoms like nausea, vomiting, and constipation. The grains.
Surgical removal, a parathyroidectomy, is the recommended treatment. But for non-surgical management, what is the priority to prevent renal complications?
Hydration therapy is absolutely critical. Patients must maintain a high daily fluid intake over 2,000 millirel to dilute the urine and prevent the precipitation of calcium salts into kidney stones.
And crucially, we have to avoid a specific class of diuretics.
We must avoid thiazide diuretics, as they paradoxically decrease renal calcium excretion, which would just exacerbate the hypercalcemia. Mobility is also encouraged, as bed rest promotes calcium excretion from the bones, worsening the risk of stones.
What defines a hypercalcemic crisis, and what is the immediate aggressive treatment protocol for it?
This is a serum calcium level greater than 13 milligdl. It causes severe, life-threatening symptoms, particularly neurologic ones.
And treatment.
Immediate treatment requires rapid, high-volume 5E rehydration with isotonic saline to flush the calcium out. This is combined with medications like calcitonin, which quickly promotes renal calcium excretion, and bisphosphonates, which are potent inhibitors of bone resorption.
Now, hypoparathyroidism is insufficient PTH secretion, most commonly happening inadvertently after a near-total thyroidectomy. The result is hypocalcemia and hyperphosphatemia, leading to what chief high-risk symptom?
Tetany. Low serum calcium increases neuromuscular irritability, leading to spasms and paresthesias.
And this can be a huge range of symptoms.
A huge range, from latent symptoms like numbness, tingling, and mild cramping, to overt symptoms like muscle hypertonia, laryngeal spasm, seizures, and fatal cardiac arrhythmias. Laryngeal spasm is the immediate airway danger.
Diagnosis relies on 2 vital physical signs named after their discoverers, Chvostek and Trousseau. How do we elicit these signs?
Okay, so the Chvostek sign is elicited by tapping lightly over the facial nerve just in front of the ear. A positive sign is a twitching or spasm of the facial muscles, particularly around the mouth or eye.
And Trousseau sign.
The Trousseau sign is elicited by inflating a blood pressure cuff above the systolic pressure for 3 minutes. A positive sign is carpopedal spasms of the hand and wrist, which indicates latent tetany.
For acute, life-threatening tetany, what emergency medication absolutely must be on standby?
Calcium gluconate must be available immediately for slow administration to raise that serum calcium.
And if the patient is on digitalis, there's a critical caution before giving them calcium.
This is a major risk. Calcium and digitalis potentiate each other's effects on the heart muscle.
Right.
So administering calcium too rapidly to a patient on digitalis can precipitate a potentially fatal cardiac arrhythmia. The nurse has to proceed with extreme caution, administering it slowly, and ensuring continuous cardiac monitoring throughout the infusion.
For chronic management, what does the necessary high calcium, low phosphorus diet entail?
It sounds simple, but it's actually pretty tricky. We want high calcium, but we have to restrict high phosphorus foods like milk, milk products, and eggs.
So even though milk has calcium, its high phosphorus content makes it counterproductive.
Exactly. We also restrict spinach, which contains oxalate that binds calcium and prevents its absorption. And to help with phosphorus excretion, we often administer aluminum binders, like aluminum hydroxide gel, after meals.
Finally, what kind of environment is required for a patient who is at risk for tetany?
The environment has to be quiet and free of stimuli. Sudden noises, drafts, bright lights, or unexpected movements can lower the threshold for neuromuscular excitability and precipitate tetany or a seizure. Protection and quiet reassurance are absolutely key.
Okay, let's move to the adrenal glands, starting with the medulla. Pheochromocytoma is a rare but potentially curable tumor of the chromaffin cells, leading to excessive catecholamine secretion. What is the classic clinical triad of symptoms?
The triad is non-negotiable for diagnosis. Headache, diaphoresis, which is profuse sweating, and palpitations, all in a hypertensive patient.
And this is often expanded to the 5 H's.
That's right, due to the excessive epinephrine and norepinephrine, hypertension, which is often paroxysmal or intermittent, headache, hyperhidrosis, sweating, hypermetabolism, and hyperglycemia. Patients experience this extreme, paralyzing anxiety during these episodes.
Diagnosis relies on measuring metabolites, especially in a 24-hour urine collection. What nursing instructions are vital to ensure the accuracy of this collection?
Since we're measuring the breakdown products of catecholamines and metanephrines, we have to eliminate all external interferences.
So what does the patient have to avoid?
The patient has to meticulously avoid foods high in catecholamines. That includes coffee and tea, even decaf, bananas, chocolate, vanilla, and red wine. They also have to avoid aspirin and decongestant medications for several days before and during the collection.
Because failure to do so results in a false positive.
A false positive test, exactly.
Definitive treatment is adrenalectomy. What is the absolutely crucial preoperative pharmacological principle regarding hypertension control?
You must control the blood pressure and expand the fluid volume before surgery. The critical sequence is to start the patient on an alpha-adrenergic blocker, like phenoxybenzamine or doxazocin, 10 to 14 days pre-op.
And that blocks the massive vasoconstrictive effects.
Exactly.
So why must the alpha blocker be given first before a beta blocker?
So this is critical. If you give a beta blocker first, you block the vasodilatory effects of beta stimulation, but you leave the powerful alpha vasoconstriction unopposed.
Which would lead to a catastrophic hypertensive crisis.
A catastrophic, unchecked hypertensive crisis and pulmonary edema. Only once the alpha blockade is established and blood pressure is controlled can a beta blocker be added cautiously to control the heart rate.
Post-operatively, what are the 2 main risks due to the sudden withdrawal of all those catecholamines?
Hypotension and hypoglycemia. The remaining adrenal gland, which was suppressed, takes time to adjust, so the nurse has to closely monitor the ECG, arterial pressures, and blood glucose, as the sudden removal of the tumor can cause dangerous drops in both.
Okay, now to the cortex and the primary deficiency state. Addison's disease-insufficient production of both glucocorticoids and mineralocorticoids, often due to an autoimmune attack.
Right, and the resulting clinical picture is really the opposite of Cushing's. The loss of mineralocorticoids leads to severe sodium and water loss and potassium retention.
Causing volume depletion, decreased cardiac output, and hyperkalemia.
Precisely. And the loss of glucocorticoids causes hypoglycemia, profound muscle weakness, and weight loss.
And what about the unique sign linked to the pituitary trying to overcompensate?
That would be hyperpigmentation. Due to the low cortisol, the pituitary oversecretes ACTH. ACTH shares a precursor with melanocyte-stimulating hormone, or MSH, and this results in a characteristic bronze color of the skin, especially on sun-exposed areas, pressure points, and mucous membranes.
Addisonian crisis is the acute, life-threatening form, often precipitated by stress. What are the management priorities?
This is acute circulatory shock. We need to administer large volumes of IV saline and 5% dextrose immediately to restore volume and manage the hypoglycemia.
And the definitive treatment?
High-dose 4V hydrocortisone to replace the missing steroids. We have to monitor for orthostatic hypotension, a drop of 20 millimeter Hg or more, which is a key sign of critical fluid depletion.
The teaching for Addison's patients is crucial for survival. What is the most important concept for them to understand about their medication?
It's the need for lifelong replacement therapy and the concept of stress dose adjustment.
Can you explain that?
During any period of physical stress, a severe cold, a fever, surgery, or even extreme emotional trauma, the patient must immediately increase their corticosteroid dose temporarily to prevent a crisis. They have to carry an emergency kit with injectable steroids and wear medical alert identification at all times.
Contrasting Addison's, Cushing syndrome is the excess of glucocorticoids, most often caused iatrogenically by long-term high-dose steroid medications or endogenously by an ACTH-producing pituitary tumor.
Right, and the excessive cortisol levels abolish the body's normal diurnal pattern, just flooding the system. This leads to that classic clinical picture that is often devastating to the patient's body image and overall health.
Describe that classic clinical triad and its consequences.
The physical markers are unmistakable. Central obesity with thin limbs due to muscle wasting, the fatty pad known as the buffalo hump, and the rounded ruddy moon face.
And the consequences are systemic.
Absolutely. Profound hypertension, hyperglycemia, and fragile thin skin that easily bruises and develops purple stria. And due to protein catabolism, they suffer severe osteoporosis and are at a high risk for pathological fractures.
Diagnosis focuses on proving the lack of cortisol suppression. How does the dexamethasone suppression test work?
We administer dexamethasone, a synthetic steroid, late in the evening. Normally, this should signal the pituitary to stop producing ACTH, which would suppress the morning cortisol level.
But in Cushing's?
In Cushing's, the next morning's cortisol level is not suppressed, confirming that the regulatory negative feedback system is broken, usually by an autonomous tumor. We also confirm diagnosis with a 24-hour urinary cortisol collection that's 3 times the normal limit.
If the management is surgical removal of the tumor, what is the critical complication to monitor for postoperatively?
Just like with a thyroidectomy, removing the overactive gland, in this case, an adrenalectomy, puts the patient at high risk for the opposite crisis, Addisonian crisis.
Because the remaining tissue is suppressed.
Exactly. The remaining chronically suppressed adrenal tissue may not be able to immediately produce enough hormone to sustain life. So the nurse has to watch vigilantly for signs of hypotension and shock and be prepared to administer replacement steroids immediately.
What are some of the specialized nursing interventions required for a patient suffering from the physical effects of Cushing's?
First, risk for injury. Because of the osteoporosis and muscle wasting, we need a protective environment and a high-protein, calcium, and vitamin D diet. Second, risk for infection is high because the steroids mask inflammation. Any subtle rise in temperature has to be investigated immediately.
Okay.
Third, skin integrity. The skin is so fragile it can tear easily. We have to avoid adhesive tape and use meticulous care during repositioning. And finally, we need to provide emotional support, reinforcing that the physical changes, like the moon face and buffalo hump, are often temporary and reversible with successful treatment.
The discussion of Cushing's flows so naturally into the general therapeutic use of corticosteroids, which are prescribed for countless conditions because of their anti-inflammatory and immunosuppressive properties. What's the fundamental principle for dosing to minimize the most serious side effects?
The cardinal dosing principle is to mimic the body's natural diurnal rhythm. The highest natural cortisol secretion occurs in the early morning.
So you give the dose then?
Therefore, the total daily dose should ideally be administered between 7 and 8 a.m. This provides the maximal necessary suppression or replacement effect while minimizing the overall Cushingoid side effects.
Let's quickly reinforce the 3 most crucial side effects and the required nursing interventions.
Okay. First, fluid retention and hypertension. This requires monitoring I&O and encouraging a low-sodium diet. Second, infection risk. The patient has to be taught to report even minor signs of illness and avoid exposure to crowds as the steroids suppress the immune response.
And third?
Third, osteoporosis and hyperglycemia. This requires blood glucose monitoring and dietary education on calcium and vitamin D supplementation.
And the absolute non-negotiable rule about stopping therapy.
Never stop abruptly. The exogenous steroids have suppressed the patient's own adrenal glands.
Okay.
Stopping suddenly results in acute, life-threatening adrenal insufficiency. The dose must always be tapered slowly, giving the suppressed adrenal cortex time to recover responsiveness, which can take up to a year.
Wow. Okay, we've covered the endocrine system, a really complex, high-stakes area of nursing. Let's try to synthesize the 3 most critical, life-saving clinical insights you need to take away from this deep dive.
Okay. First, master the fluid and electrolyte distinction between the pituitary disorders.
DI versus SIAD.
Exactly. If the patient is dumping liters of dilute urine, DI, the problem is dehydration and dangerously high sodium. If the patient is holding on to fluid, SIDH, the problem is dilutional hyponatremia and dangerous neurological compromise. Knowing which one you are fighting dictates your immediate intervention.
Okay, that's number 1. What's number 2?
The ability to instantly recognize and specifically treat the 2 thyroid crises. The clinical presentation is your cue.
Myxedema coma versus thyroid storm.
Right. Myxedema coma is slow, cold, and depressed, requiring caution with sedatives and passive rewarming. Thyroid storm is hot, fast, and frantic, requiring aggressive cooling with no aspirin and immediate cardiac stabilization. Your response has to be condition-specific.
Perfect. And number 3.
The critical medication safety protocols surrounding corticosteroids emphasize the long game. For any patient on steroids or with adrenal insufficiency, the core teaching is the stress dose adjustment for illness, surgery, or trauma, and the mandate to never stop the medication suddenly due to the risk of a fatal Addisonian crisis.
You know, we began by noting that many of these endocrine disorders are insidious. They masquerade as simple stress or fatigue. We rely so heavily on the history and a physical exam to identify them.
We do. So given the vagueness of those early complaints, the challenge for the clinical nurse isn't just knowing the formal diagnosis. It's utilizing those incredibly detailed physical clues, the small, specific signs like hyperpigmentation on the knuckles, the specific pattern of fat distribution, or the thinness of the skin.
To distinguish simple aging or lifestyle stress from the early, subtle onset of severe life-altering conditions like Addison's or Cushing syndrome.
Exactly. How do you, as the primary assessor, pivot from a general concern to a targeted investigation based on those specific physical details?
Yeah.
The endocrine system reminds us that meticulous observation is really the cornerstone of great nursing.
A truly powerful thought to chew on. Thank you for joining us for this crucial deep dive into endocrine essentials.